our first official HPB Grand Rounds because last time I think we were drinking virtually. Just on behalf of everyone, I just want to welcome everyone. I've sort of been helping get this going. I'm just going to hand over to Dr. Visser in a minute to say a few words as the chair of the Program Directors Committee. Just want to thank everyone for joining. A couple of ground rules. Please keep muted unless you want to jump in with a question or comment. Use the chat function liberally. This is for all of you, and we really want to hear what your thoughts are and what your questions are. These presentations are meant to be at a postgraduate level. This is not residency level choledochal cysts and cyst management. This is postgraduate level as an HPB. So we really want you to jump in and sort of be, at that level. I want to thank Dr. Padmore for being the inaugural presenter this year. Thank you for taking that on. He's presenting from Calgary and is talking about cysts and malformations, choledochal malformations, which I think is a really great topic with something that we don't always see and is a good thing for all of our fellows to have some input regarding and some education regarding this. Dr. Kevin Shah has kindly stepped in for our moderator today from Duke, and I appreciate you doing that, Dr. Shah. Again, ground rules, please keep yourself muted unless you want to join in with a question. There'll be some natural pauses during this presentation, and we typically want to do this with some sort of case-based discussion to start out with. Dr. Visser, can I hand over to you and then on to the presenters? Thanks for the opportunity to welcome everyone.
No, thanks. I'll let Greg get started. Kevin, if you can keep your eye on the chat box, questions come up. Sometimes it's hard to be paying attention to the presenter, but otherwise I'll try to ping you as well.
Sure.
Because we really would encourage people to be able to make this interactive. I think we're all getting better with Zoom over time, so it's great to ask questions and push and bring up controversies, because there's a lot of stuff we don't really have the answers to in this specific area.
And I'm just going to repeat for everyone, please relabel yourself with the 3 dots with your institution so that we know who's on. If you possibly can, please give us, as in the famous words of Lady Gaga, show us your teeth. We'd like to see you, not just see your black screen, so that we can actually see, really get some engagement over here. It's sometimes hard to look to a bunch of blank screens. So without further ado, Kevin, can you take it off?
Sure. Thanks, Rohan. I'm filling in for Dr. Zani, who is not quite as fast as he thinks he is in the OR, and he's unfortunately stuck there. So I've had a chance to look over Greg's presentation. I think he'll offer a lot of points for interesting discussion. So Greg, why don't you go ahead and take it away?
Good afternoon, everyone. So I'll be doing a talk today on choledochal cysts, or also known as choledochal malformations. I'm Greg from Calgary. So we just get started. How I have the outline today, I have 2 case presentations, 2 index cases. Then we'll jump into the introduction, background about the choledochal cysts, diagnosis, treatments, and summary. And throughout the presentation, we have some discussion. So jumping right into the first case, it is of a 32-year-old female. She was referred to our HPB clinic after an ultrasound scan was performed for non-radiating upper back pain. This pain was deep, no relieving or aggravating factors. She didn't have any weight loss, decreased appetite, or biliary obstructive symptoms or change in her bowel habits. Her past medical history is non-contributory. She did have a tonsillectomy as a child, but social history-wise, just smoked cigarettes, but no recreational drug use. When we saw her, she was comfortable. She was anecteric, abdomen was soft, non-tender, no masses or organomegaly appreciated. She presented with the ultrasound scan, and that actually showed a fusiform cystic structure in the porta hepatis, measuring about 2.7 by 3.9 by 5 centimeters. And it was in communication with the common bile duct. The cystic duct was favored to drain into the common duct. This was proximal to the cystic lesion, and there was no intrahepatic biliary duct dilatation, or no gallstones. Appreciated.
So why don't we pause here for a second?
Sure.
So, it's just one static image, but why don't we go to Mo at Hopkins? So can you go back to that image?
Yep, this is our MRCP image, yeah.
Yeah, so what do you make of this image? What do you want to do for the rest of the workup, and what's your plan for management of this lesion?
This looks to me like a type 1, assuming that this is a choledochal cyst. As part of the workup, I'll probably also get an EGD within EUS just for further information. Sometimes just, getting a brush cytology just to make sure we don't have cancer. So we'll also send out tumor markers as well. And I think that this MRCP is enough. I wouldn't get a CAT scan on top of that.
So what is your discussion with the patient? You get, let's say you get an ERCP and you brush it and it's negative for any malignancy. What are you going to tell the patient what the next steps in management are?
I would counsel the patient that right now what we think this is a choledochal cyst, which is, I'd explain it to him in basically simple words, that it's basically just a dilation of your bile duct, and that it has the risk of becoming cancer. After I confirmed that it's, that it's not cancer, so that's, the name it part. If I had any suspicion for cancer based on the tumor markers or anything, then I would do a staging workup. And then after that, basically the intervention would be surgical resection, because, I explained to the patient that there's no medical management of this choledochal cyst, that it's usually managed surgically.
Can I ask a question? Would other people do brushings this recently? Actually, somebody, Martini suggested it in a case forum on an HPV, case series. I wouldn't if I didn't have cross-sectional imaging that suggested I needed to, because in a young woman like this, if you're going to get post-ERCP pancreatitis, this is the patient, right? Young women, highest risk. So I wouldn't cannulate the bile duct unless I.
And his CMV was different.
Yeah, I agree with that. I definitely would not typically get an ERCP in this case. That was going to be my next question for the group, if anyone would.
I think the, biliary fish can be very helpful for patients sitting on the fence. If you've got a, trisomy of the affected chromosomal arms, that's basically, it elevates your cancer risk from 20 to almost 80 to 90%. So that's where I've used it.
And Dr. Cleary, would the operation change for you depending on that result?
Yeah, I probably would. I'd probably do a much more thorough lymphadenectomy and take a more sort of, oncologic approach, like in terms of getting wide margins. And, these things can often, depending on the patient, they can have had a history of cholangitis, so they can be stuck, and it influences your interpretation of stuck. So if your biliary fish is positive, stuck could mean cancer. So you're going to take, it just kind of changes your mindset and changes your approach.
So I actually just want to comment that I've actually had a couple of these that were manipulated and got infected, and that changed everything, which was really painful because they don't drain well. But Kevin, in the interest of time and letting Greg present, let's keep moving.
Okay. So as we see on this MRCP image, she had a fusiform dilatation of the cystic duct, the common bile duct, the cystic duct drain into the normal diameter common hepatic duct. The dimensions of this was about 4.7 centimeters in length and 3.5 centimeters in width. And it tapered down as it met the main pancreatic duct. around this region here. So given this, based on her type of cyst, she had a type, yes, I agree, type 1, likely a type 1C. Choledochal cysts is a fusiform dilatation and a cystic duct entering the normal common hepatic duct. We discussed benefits, risk of observation versus surgical removal with her in detail, and this culminated in her agreeing to our advice for surgical resection. At that time, we booked her and we went on ahead and did an open extrahepatic bile duct resection and a cholecystectomy. Proximal to the cyst, we were able to locate a normal caliber common hepatic duct, and that marked the point of proximal transection. And once that proximal transection was done, we were able to dissect the cyst safely off the portal posteriorly and as low down as we could, coring into the head of the pancreas to get the distal aspects of the cyst. And that pancreas and that distal common bile duct was sutured with full PDS. Then reconstruction was achieved with a Roux-en-Y hepaticojejunostomy. And postoperatively, she did well, spent about 5 days post-op, and pathology confirmed benign epithelial line cysts. And this was consistent with choledochal cysts, no malignancy found. All right. So any questions? Yeah.
Oh, go ahead.
Mm-hmm. No, any questions on the first case?
So,
yeah.
So first of all, what's the long-term surveillance plan for this patient? Is there one?
At this point, she'll be followed at least every 6 months, initially for at least 2 years. That was the initial plan for her. In terms of imaging wise, she should get at least an MRCP once a year, just a reassessment of that pancreatic, that distal aspect of the bile duct.
How long do you do that for?
Well, follow-up really should be at this, based on what literature said, is maybe it should be lifelong in terms of follow-up. I'm not too sure of the imaging follow-up, but we should keep an eye on her just because of the risk of development of cholangiocarcinoma, more so in the remnant distal end of the common bile duct.
Dr. Visser, do you follow these patients lifelong?
I do. Couple of thoughts. One is just to everyone keep in mind, your path report says choledochal cyst because you wrote on the requisition choledochal cyst. Mm-hmm. If you had written biliary obstruction and dilated bile duct, they would write dilated bile duct.
Okay.
Right? The epithelium looks the same as the bile duct. Yes, I think what Dr. Shaw is getting at is that there is this risk of cancer despite you're resecting it that is not, it's just a few percent, but it doesn't go back to the baseline population. So I do survey patients absent any data telling us that we're actually going to detect cancers early enough to intervene with MR in these young patients because it seems easy, and there's little downside to doing it. I think that probably I worry more about the actual intrahepatic biliary tree and the fact that, our hepaticojejunostomy is perhaps itself carcinogenic. I think that the remnant bile duct in the pancreas down below is probably not, for most patients, going to be the thing that I worry about so much as I do actually right at the hepaticojejunostomy when I'm looking at those MRs. But I do survey them every year or few years, essentially sort of indefinitely.
Okay.
But I have no data.
Yeah. So Dr. Hawkins and others made a couple comments in the chat. One question, Dr. Hawkins, maybe you can answer this. If this patient were 75 years old instead of 32, does that change your indication to operate? Or would you operate regardless?
I think you have to take all the important points into consideration. There are 75-year-olds with a 20-year life expectancy, and there are 75-year-olds with a 5-year life expectancy. So I think you take all that information into consideration. But I have some patients under surveillance because of other health issues or heart transplant patients that I am just watching.
All right, and we're going to get to the anomalous pancreatic biliary junction issue in a little bit. So Greg, why don't you continue with the next case?
Okay, all right. So the second case is a 48-year-old male. He was admitted previously with acute pancreatitis. At that time, it was of unclear etiology. And this was a few weeks prior to our consultation to our service at another hospital. While he was there, his evaluations and investigations culminated in a contrast-enhanced CT followed by an MRCP imaging. He was otherwise well on good in terms of his medical history, no smoking, alcohol, or illicit drug use. When he came to our clinic, he was a fit, healthy young male. Abdomen was soft to benign, no organomegaly appreciated. He presented, of course, with his imaging. This is first of his CT scan, and as we can see, it pretty much showed a cystic dilatation of the common bile duct, but interestingly, also his cystic duct was also dilated, and for a bit of portion from this cut, we can see right and left hepatics were also a little on the larger end, but could be just a variant. His MRCP also similar. Yeah. Mm-hmm.
Oh no, go ahead. Wait, since you pulled up the MR, why don't you
sure.
go with that?
So, and his MR kind of confirmed what we saw, where you have a cystic dilatation of the common bile duct here, and it seems like a proximal to the cyst, kind of tapering down of the common hepatic duct. And on this imaging, the radiologist did note that his pancreatic duct, in addition to the point of joint where the pancreatic meets the common bile duct, there was about a 1.6 millimeter common channel before it reached the ampulla vata. It's not well represented on this cut, but he did have also an anomalous biliary duct union.
All right, so why don't you pause there for a moment?
Sure.
Are any of the fellows from Toronto on? Let's see. I thought I saw someone.
Dr. Patel, Dr. Raschak.
So, you know, if you go back to that previous CT image, you've got a big cyst. You know, obviously this is a static image. It's a little hard to tell what's what, but you've got a big cyst in the pancreatic head in someone who is presenting with pancreatitis. What's your thought process in how you're going to work this up and what the etiology is of it?
Well, first you have to address the acute issue, dealing with the acute pancreatitis. Definitely, when we look at the causes, it's non-alcoholic, no gallstones seen on ultrasound, then we have to assume that this cyst, which is the choledochal cyst, could be contributing, as majority of these, especially type 1s and 4, have a anomalous pancreabiliary junction. So once we rule out the common causes, and we do have an imaging such as this, then we would assume that this choledochal cyst is the cause of the pancreatitis, given the likelihood that he does have confirmation that he does have a anomalous junction, that is being shown to be a cause as well of acute pancreatitis.
Yeah, so I mean, I think the first point is, you know, just because someone has a choledochal cyst, you can't just presume that that's the cause of the pancreatitis.
Correct.
There are other more common causes that could be a culprit. And then the second thing is, sometimes if you have a giant cyst in the head of the pancreas and some dilation of the common duct proximally, it's hard to interpret whether there's something else going on in the pancreatic head that's resulting in the dilation of the common bile duct, or if this is in fact a choledochal cyst. So I think those are a couple things to keep in mind. Okay. All right, Greg, why don't you keep going?
Sure. All right, so at his, basically just have a schematic diagram of what we've discussed so far, where you have a common channel, a common channel, where the pancreatic duct and the common bile duct meet. And this long channel usually is what is referred to as the anomalous biliary pancreatic union. And this is what results in, or theoretically results in, the reflux of pancreatic enzymes proximally up the common bile duct, more commonly in type 1 and type 4 cysts, to result in that cystic dilatation there.
All right, so why don't you pause
Sure.
there? So let's go to Alejandro. So what operation would you plan in this situation? Let's say that there's no other obvious cause of the pancreatitis, and on imaging and on EUS, there's like a bunch of debris in the cyst in the intrapancreatic portion, and you're convinced that this is the cause of the pancreatitis. What's your operation going to be?
Yeah, I mean, I'm actually debating that right now in my head, because if this was a cystic lesion that had both extra and intrahepatic components, that would typically classify this as a type 4, and that would in some ways involve a hepatectomy. But if the cystic lesion is going down close enough to the pancreatic duct.
So what about in this case? Why don't you go back to the MR image?
Yeah. I mean, the operation, I mean, for a non-proven cancer, a Whipple and a right hepatectomy seems a bit extreme. But yeah, it doesn't sit well with me. I would need more information.
Someone said Whipple, I heard.
Yeah.
Anyone else would do a Whipple for this case? And what your reason for doing a Whipple is to prevent recurrent pancreatitis, is that correct?
Well, it depends on, just looking at the MR, if the cystic dilation goes down close to the insertion of the pancreatic duct, then in order to prevent recurrence or doing an inadequate operation and leaving dilated duct behind, if I need to resect the head of the pancreas, if I need to resect that portion of the duodenum, then the head of the pancreas would have to come out.
So Dr. Ionity is proposing maybe doing an ERCP and a pancreatic stent.
Yeah, so, and this is what I was alluding to. I mean, in the absence of biopsy-proven cancer, an extreme operation doesn't sit well with me.
Yeah, okay. Dr. Allen, you agree doing a Whipple in this case? Do you like that idea?
I don't love the idea. I guess it depends on what your goal is of the operation. Alejandro said that the goal would be to remove all of the dilated ducts. Well, if that's the case, it looks to me like the left duct and right hepatic duct, are dilated all the way up into the anterior and posterior sectoral branches. So, this is a risk reduction operation. We are not getting rid of the risk, as Brendan said in the last case. The patient still has risk. They're going to be followed annually. So I guess you have to determine what risk you're willing to accept and what level of, quote, risk reduction that you're going to provide that patient, because you're not going to craft any operation here where all of the dilated ducts are going to be removed. So I try to avoid a Whipple procedure. I think you could probably dissect down pretty low into that pancreas to get close to the duct junction. And I'd avoid a liver resection. You're not going to get all the way up to the normal ducts in the liver on both of those sides. So you're just going to have to accept what risk you're willing to take.
Yeah, and I think based on the comments, there's near unanimous agreement from the faculty not to do a Whipple in this situation.
Kevin, I just wanted to jump in. Technically,
Yeah.
one thing I really find helpful is just divide the duct in the middle, peel it down. It comes down to a little nubbin where the PD comes in. As David said, it's helpful if you have a PD stent in place. I just always worry about pancreatitis risk. But one of the things is just don't be afraid to divide this into two, peel up, peel down.
Yep. And Greg, if you want to keep going,
Sure.
I think that's in fact what they did.
No problem. So yes, we actually did him this morning. We ran pretty much, lifted the gallbladder off the cystic plate. This here is where we found the dilated cystic duct. We have the vessel loop around the kind of decreased normal caliber common hepatic duct. And in this portion here is where we have the cyst, type 4 choledochal cysts. So in terms of technically what we did, as Dr. Rohan was suggesting, we transected proximally at the junction between the common hepatic and the cystic dilatation, where we can see the portal posterior. It was a bit sticky there, but we were able to obtain a plane and pretty much went as low down as we could have into the pancreatic head and transected it at that level, and oversewing that distal aspect of the choledochal cyst. So this is it, kind of decompressed cystic dilatation here of the cystic duct, and in this region here would have been where the type 4 cyst is. And we went as low down into the pancreatic head as we could. Reconstruction-wise, we did a hepatico jejunostomy. Any questions or more questions from the case?
And just very briefly, so we can move on.
Sure.
There are a couple people advocating for hepaticoduodenostomy. You know, I can't remember who it was, but do you worry about cholangitis or SUMP syndrome or anything like that doing, or excessive tension, sewing this to the duodenum?
For hepaticoduodenostomy, it is technically possible, but definitely you have to consider him having being able to fully get that duodenum up there without tension. In this gentleman, he did have an episode of pancreatitis before, so even behind the pancreatic head, when we did our cockers for mobilization and stuff, it would have been a little challenge getting that duodenum up to that hepatic duct. And in terms of outcomes from the literature, both hepatico-jej and hepaticoduodenostomy have similar in terms of outcomes. So for our point of view, ensuring a tension-free repair, we were easily able to get a loop of jejunum up there and perform a hepatico-jej in this case. But definitely you can perform hepaticoduodenostomy. They're more commonly done in pediatric population, but in this case, we did a HJ for him.
Okay. All right.
If I can jump in, Kevin.
Yeah,
so I think my old partner, my current partner, sorry, Tom Beal was the one who mentioned the duodenostomy, and he does a bunch of those. And we actually had Bart Rose, one of our former residents who's at UAB, actually did write that paper to show that they were equivalent. And they can reach up to the GE junction if you want them to. So I think that the tension is less of an issue. I don't do it personally because my worry is that the part of this operation is to get the pancreatic juices away from the bile duct. And if you just plug the duodenum there, then you haven't really solved that problem. So that's the other reason why we don't.
Okay, great. Greg, why don't you keep going?
Okay, go ahead. Oh, there's Tom.
Oh, sorry.
Yeah, I'm the one who asked the question. I'm always curious about it because I have written it up, and many people think that the duodenum doesn't really reach high in the bile duct, and it's not true at all. It will reach easily to the bifurcation, and occasionally if you've done a liver resection, it'll reach to the left hepatic duct or the right hepatic duct to do a reconstruction. And it's certainly much easier to endoscopically surveil, or if you get a stricture or something that you need to endoscopically deal with, it's much easier to do it if you have a duodenal anastomosis. Many times if you have a Roux-en-Y, jejunal anastomosis, the repeat access to that has to be transhepatic, which is not without complications. So that's one of the reasons I do it. We have not, despite many procedures, I have not seen a high incidence of cholangitis. Generally, if there is cholangitis, it tends to be due to a stricture at your anastomosis. And if the bile flow is normal, which it is generally, you don't get cholangitis. And then with regard to the mixing of pancreatic enzymes and the bile, yes, that is a potential concern, but we've not seen recurrent cancer because of that. And if that were the case, then every single one of these papillotomies we do endoscopically would potentially be at risk for that. We commonly see air and other things reflux into the bile duct after papillotomy and after many bile duct reconstructions. So I don't think that's a valid concern. Those are just my comments. And that's why I brought it up. Just curious what people do.
I think that a hepatoduodenostomy is great. It works well. I think it's overstated the risk of reflux cholangitis also. For complex stone disease is an operation that I do now and again. The pediatric surgeons went away from roux limbs. Most of these choledochal cysts I do with the pediatric surgeons. They went away from roux limbs about the last 5 years because they had more complications with making the roux, like small bowel, volvulus kind of complications unrelated to the hepatoduodenostomy. So with the pediatric surgeons, we started going to using the duodenum in kids, in small kids. But now I've had two very odd circumstances where when these kids got to be, in one case, 16, in one case 19, and as a student at Columbia, I actually took down her hepatoduodenostomy and gave her a roux limb because she had pain from essentially duodenal contents refluxing up. She'd drink cold water and she would get right upper quadrant biliary colic type pain. So that is weird, and that was new to these young kids who had an anastomosis early on, and then later on had symptoms that I've never seen that in other adults who are doing a hepatoduodenostomy for other reasons. But it was slightly odd, and we're taking a couple of these down now.
Okay, great, thank you. Greg, why don't you keep going?
Okay. All right, so just moving on to our discussion of these cases. Choledochal cysts, some recent change in the term in the literature, calling more so choledochal malformations. They represent a spectrum of congenital biliary tree anomalies. They're really rare in the Western populations. There's some quotes of 1 in 100,000 to 1 in 150,000 individuals, but definitely in the Asian populations, it can be, they are more common with an incidence of 1 in 13,000. Given the congenital nature of course, you definitely will see them more diagnosed in children, but there are some reports of being increasingly diagnosed in adults. There is a female preponderance, about a 4-to-1 ratio. Historically, just for our knowledge, these cysts were initially cyst decompression with a cyst enterostomy was the management of choice. However, the cyst excision with a biliary enteric reconstruction currently is the standard management of care. And this is all given the long-term risk of malignancy in these choledochal cysts. In the general consensus of the underlying etiology is an anomalous pancreaticobiliary duct union. And as I described a little earlier, in essence, that involves having a greater than 1 centimeter long common channel. This is proximal to the ampulla of Vater. The hypothesis is that this predisposes to pancreatic enzyme reflux into the biliary tree, and then you can have resultant biliary duct inflammation and pressure, and that can lead to the ductal dilatation. I just have a schematic image pretty much showing what is normal, where the biliary common bile duct and the pancreatic duct both join within the wall of the duodenum as they meet to form the sphincter of Oddi. But however, in these anomalous junctions, this joint point occurs before it reaches the sphincter, and the common duct or the common junction is pretty much outside of the sphincter, and this is how the reflux can occur. As we mentioned in the second case, this was indeed the cause, was indeed found. He had a 16 millimeter abnormal pancreabiliary duodenal union. And approximately 30 to 96% of patients with choledochal cysts have this malformation. Todani, a Japanese surgeon back in the 1970s, is who gave the classifications to these choledochal cysts, where type 1, as we just look at a diagram, type 1, as our patient had in the first case, occurs in 60 to 80% of the cases, and it's really have a cystic dilatation of the common bile duct, and that can be broken down into 1A, B, and C. In type 2, this is where you have a supraduodenal diverticulum, not so common, 1 to 2%. Type 3 cysts, even less common, where this is what we refer to as a choledochal seal, which is at the very distal aspect of the bile duct. You have a cystic dilatation there. Type 4, you have that occurring is type 4A, where you have both intra and extrahepatic biliary ducts involvement. And type 4B, less common, where you have only multiple extrahepatic duct dilatation. And type 5, which is rare, but is also, as you know, known as Clarolles disease, where you only have intrahepatic duct dilatation. So just overall, remembering type 1 and type 4 are the most common cysts that you would encounter. Interesting to note, the abnormal junction is more frequently occurring in type 1 and type 4 cysts. And that is what the prolonged pancreatic secretions there is what is the theory behind what the malignant degeneration of the biliary epithelium occurring. Type 2 and 3 malformations might be true congenital malformations, and in these cases, the abnormal junction is absent. So therefore, reflux is absent in these cases. Just to show again, type 2, supraduodenal diverticulum, and type 3, choledochal cysts. These are considered more the true congenital malformations. In terms of the diagnosis, approximately 80% of these cases present in childhood. Symptoms in children tend to range from non-specific abdominal pain, hypochondrial pain, jaundice, nausea, vomiting. In adults, in particular, it may range from abdominal pain, infectious complications, pancreatitis, malignancy. Overall, abdominal pain is the most common presenting symptom, 72% in adults, 41% in children. Pancreatitis, in addition, can be found at presentation in 18% of the cases. In addition, jaundice in 18%, 16% of patients definitely can be asymptomatic, and usually these are detected on cross-sectional imaging being done for another region. Another reason, 10 to 36% of these cysts are detected that way. In terms of workup, some patients start off with getting an abdominal ultrasound scan if for non-specific abdominal pain, or they can start with getting a CT abdomen, which usually starts the workup, especially in the asymptomatic patients. However, once this is detected, an MRCP should be done for optimal modality for obtaining detailed information of the biliary anatomy. In terms of the treatment, once you have obtained, remembering that we must always treat the actual underlying presenting complaint, whether it's a biliary infection or pancreatitis, but once that is treated and you obtain your MRCP, the next step is for determining what will be the best management for the type of cyst you have found. The principles of definitive management, they are based on the type of cyst and the aim to manage recurrent acute inflammatory conditions and the risk of malignant transformation. 90% of patients with malignancy are associated with type 1 and type 4A choledochal cysts, and this is in contrast to the rare incidence of a malignancy, which in types 2, 3, or 5. So again, if a malignancy is to occur, it usually occurs in type 1 and type 4 cysts. And that is important because the principles surrounding the decision for surgery are fourfold. You have to look at the degree and the severity of the symptoms the patient is having, the type of cyst, again, because of the risk of malignancy associated with the type of cyst, patient's age, and the comorbidities, and then ultimately what operation is required for a complete or at least a near complete excision of that cyst. So the rate of malignancy can be divided pretty much into tumors which present at primary surgery, tumors present at primary surgery, or tumors that develop during follow-up. In a meta-analysis which was focusing on the malignancy risk in choledochal cysts, this was out of 2,900 patients, 7.3% of these tumors had, 7.3% of these patients had tumors at primary surgery, and 3.4% had developed tumors during follow-up. In this meta-analysis, the median follow-up was 6 years, but the longest patient was being followed for up to 28 years in this meta-analysis. Of these 3.4% of patients, 42% actually had undergone some form of drainage procedure in the past. So these were in the early era of cyst enterostomies. The median age for patients who developed malignancy in the follow-up period was 49.5 years. 91% of patients who had tumors at the time of surgery, again, had type 1 and type 4 cysts, with 99% of patients who developed transformation during the follow-up period, again, had type 1 and type 4 cysts. Type 2 and 3 had no malignant transformation in that meta-analysis. In this review, it's interesting to note that the younger median age of 49 years for the development of cholangiocarcinoma, and this is compared to the general cholangiocarcinoma with median age of 65. Given this, you must aim for a complete or near complete cyst excision, even in an asymptomatic elderly patient, as what was discussed earlier. So it just depends on patient's life expectancy and patient's underlying physical status. Malignant transformation, as expected, it is indeed higher in the Asian population. Cyst excision and hepaticojejunostomy with a Roux-en-Y is an acceptable treatment. And if you look at type 1, you must always include a cholecystectomy, and as I mentioned, as a complete cyst excision as possible. Occasionally, the cyst may extend into the pancreatic head, as we would have seen in our second case, and you definitely have to weigh the benefits and the risk of performing a Whipple. Again, coring into the head of the pancreas is performed for more distal removal of the cyst, and that is pretty much what is, as we discussed earlier, what is the preferred option. Some persons have even described trying to strip the mucosa of the distal common bile duct, just again to try to decrease the chances of malignant transformation in that distal common bile duct. Type 2 cysts, they can undergo simple excision, again with or without a hepaticojejunostomy, just depending on if the bile duct is narrow. These are for your supraduodenal diverticulums. Type 3 cysts, these are best managed by unroofing, whether endoscopically or transduodenal sphincteroplasty. For the larger ones, you may consider transduodenal excision surgery. Now, type 4 cysts, again, these are managed differently based on the absence and the location for those that have intrahepatic disease, because some of these cysts can have such as stones forming within the actual intrahepatic dilated portion. The extrahepatic bile duct should be excised, and patients with dilatations and stenoses of the intrahepatic ducts, whether you have intrahepatic duct stones as well or parenchymal atrophy, you may benefit from doing a hepatectomy in those cases. So again, type 4 cysts without indications for hepatectomy should be pretty much treated similar to type 1. Patients who progress to malignancy most commonly developed extrahepatic cholangiocarcinomas or gallbladder cancers in 95% of these cases, whereas intrahepatic cholangiocarcinoma rarely occurs. And this was in a paper published back in 2011 in South Korea. Now, type 5 cysts, these are difficult to manage given their location. Some of these patients with Caroli's disease can have focal disease pretty much on one side, so hepatic lobectomy may be performed, but for those with diffuse both right and left duct disease, liver transplantation provides a durable option.
Dr. Orloff, do you want to comment on the role of liver transplant in this day and age for the management of, choledochal cysts or type 5 cysts?
Yes, can you hear me?
Yes.
Yeah, no, I think that's still an indication. I can tell you in the last 25 years that I've been doing liver transplants, I've done 2 for Caroli's. Typically, if there's one lobe that is more involved than the other, I take out the more involved lobe and then survey the patient very carefully. So those are 2 approaches, either liver transplantation to remove the whole liver or remove the liver lobe that is more involved with that duct, of course, and then survey the patient. So those are kind of the 2 options, but it still is an indication for liver transplantation. It's just fairly rare because the disease is fairly rare.
Great, thanks.
Great. Can I interject here and emphasize something that Peter Allen said, which I think is really an important way to think about this. For example, Greg, what you said, and I know that folks have cited this, that people are stripping the mucosa to reduce malignant transformation. That is, to me, not a completely logical thing. Well, because much of what we do is cancer surgery, and we think of removing a choledochal cyst because it's been labeled as a choledochal cyst, as like it's a cancer operation. But that's not the case. The biliary epithelium of the cystic component of the is in fact the same biliary epithelium that's above and below the cystic component. So we are trying to reduce this inflammatory nidus that results in cycles of inflammation and healing that is a premalignant condition, just like recurrent pyogenic cholangitis. And Rohan cited a patient, for example, in his own experience that might have had an intrahepatic biliary cyst disease or might have had RPC. And the reality is those 2 diseases overlap, and we have a difficulty distinguishing them. And RPC results in malignant transformation because of ongoing inflammation. So as Dr. Allen suggested, for type 4 and type 1s, we resect up to the hepatic confluence. And the intrahepatic component of the type 4s, if you follow them, will nearly universally just deflate. Once you've taken away this extrahepatic fusiform portion, the intrahepatic bile ducts will come back down to a more normal size because you've reduced the weird flow-limiting anatomic abnormality. So we're not doing cancer surgery. We're taking away these reservoirs that result in stasis and inflammation that ultimately ends up being a nidus for that transformation towards cancer. So I think that it's like in patients with strictures and stone disease and recurrent troubles with cholangitis, removing intrahepatic components just like RPC makes sense. But removing in the radiographic intrahepatic component just to have removed more cyst mucosa does not make sense to me in how I really think about this disease.
Okay.
Great, thanks. And then Dr. Helton, do you want to expand on your comment? When I think about detecting patients with anomalous pancreaticobiliary junctions, usually that's discovered because they're having symptoms. In what situations have you had asymptomatic patients with anomalous junctions?
Yeah, thanks for asking. So we have a very, very large cohort of patients over the last 20 years. We presented our data at the HPBA a couple years ago. We're in the process of publishing it. It will be the single largest experience in North America from a single institution. To make a long story short, we have a cohort of over 50 patients that are being observed that are asymptomatic. Some have an anomalous PBJ, some do not. I think in one of your slides you showed this big broad range of the presence of an anomalous PBJ. So there are many, many patients with choledochal cysts that have no anomalous PBJ, and we're throwing out there for discussion the issue. Maybe the risk of cancer in these patients is super, super low. Everybody has to realize that
just about everything that's been talked about today and that's in the literature comes from Asia. And there's very little longitudinal experience and publications in the West, whereas you said the incidence is so much less than in Asia. So Caucasians are clearly not Asians when it comes to their genetic history. And whatever the factors are that lead to cancer, I don't think are clearly delineated. There may be an asymptomatic patient population out there without anomalous PBJ who it's reasonable to follow over time. Of course, it will take decades of an observational cohort to really know if that strategy is safe. But in our experience right now, we have over 500 patient observed years without anybody developing a cancer. That's 50 patients on average being observed for 10 years. Many of whom whose choledochal cysts were discovered when they were teenagers and have lived into adulthood asymptomatic. So interestingly, when we broke it down by presence and absence of anomalous PBJ, there's a lot of patients that are completely asymptomatic with an anomalous PBJ. I can't remember the exact numbers, but it's kind of split down the middle. You would think that people with a little pinhole bile duct coming into the pancreatic duct would eventually develop symptoms, stones, pancreatitis, whatever. But there are patients out there that completely remain asymptomatic. And so the issue, especially when you get into the older age groups that have medical comorbidities, I think close observation is a reasonable strategy in those patients.
Scott, can I ask a question? This is Sue Orloff. If they're asymptomatic, how do you discover that they have these?
Heck, they just have to go through the emergency room once.
That was my question. So
right, they're discovered. They're discovered for other reasons. You know, they get an ultrasound. Many of these patients have had gallstones. They get operated on. Their gallbladder comes out, and at the time of operation, the surgeon discovers a choledochal cyst with their cholangiogram or with the imaging, but they don't touch it. And then the patients get worked up. They get referred to us. That's probably the single largest where these patients come from. They've had a previous cholecystectomy, or they've had an imaging study for God knows what reason.
Okay, great. And then Dr. Jayaraja raised the question. Why don't we go to Tasha Lay? So, you know, Dr. Jayaraja is asking about the differential diagnosis of sphincter of Oddi versus choledochal cyst. So, first of all, what is sphincter of Oddi dysfunction? Is it a real thing? In what situations does it lead to something that requires an intervention?
I think it's more of it's a you know, mechanical dysfunction of the sphincter where it's tight, and it can mimic biliary type symptoms, definitely. And I think, you know, there's been some talk that a cholecystectomy may or may not help with this sphincter of Oddi dysfunction, but I think that you know, I think some people believe that it's not really a thing. Some people believe that it kind of is a thing. I'm not sure what the data says, to be honest. But
Kevin, I think my point here was that SOD can cause biliary dilation.
Yeah.
And so sometimes we're faced with a 1.2 centimeter duct post-cholecystectomy that looks kind of fusiform dilated, and telling the difference between these two is a real life issue that you are all going to have to face as fellows, and trying to figure out if this is post-chole dilation or is this a small choledochal cyst that you're being asked to resect is really a challenge. And I just kind of wanted, you know, David Iannetti, do you want to just comment on how you approach that? David, are you there? Okay.
Sorry, Rohan, I was having technical difficulties.
Yeah.
What was the specific question about sphincter of Oddi dysfunction, or what?
So, you know, dilated bile duct related to SOD versus choledochal cyst. How do you differentiate the two?
Well, typically we like to do ERC if we're not sure. as somebody mentioned, you might have a biliary, excuse me, an ampullary stricture. That has to be ruled out. And then secondly, we'll go ahead and proceed with an ERCP. And typically we like to do spyglass so we can directly visualize the mucosa of the common bile duct, and occasionally do biopsies, and that can help differentiate.
So I think David's bringing up a couple of points. So one is you do have to rule out a distal thing. So for me, if you're at all concerned in the US, I think it's helpful to make sure that you're not dealing with a neoplasm. But the second thing is some pathologists will say that they can differentiate some choledochal cysts. I don't know what the changes are. I agree with Brendan. I think that they look exactly the same. But this is a real life deal that you have to tell the difference between a choledochal cyst and an SOD. The other thing is typically with a choledochal cyst, you'll kind of get shelving in and then normal intrahepatic ducts quite abruptly at the hilum. I just wanted to bring that up, Kevin, because this is something I have to face on a fairly frequent basis.
I'd like to add something to that. This is Dr. Helton. In a patient with a choledochal cyst, kind of looks like a type 1. You might think it's a type 4, and they present with pancreatitis. You always have to think it could be a type 4B where there is known sphincter of Oddi dysfunction. We as surgeons rarely see that anymore, but the treatment for that years past was not only to excise a type 4 choledochal cyst, but to do a transduodenal sphincteroplasty. Now the endoscopists just take care of it for us. But in the original description, pancreatitis has been associated with the sphincter dysfunction.
Great. We're running a little bit low on time. Are there any other, actually, why don't you just go, Greg, very briefly, go to some of the challenging scenarios.
Sure, no problem.
Briefly about the Lilly technique and other things.
Just quickly, don't forget MIS treatment is indeed a feasible option for these patients, more commonly than in the pediatric population. Again, more commonly for type 1 cyst in 70% of these patients. I had just added some challenging scenarios to discuss among everyone. In a scenario where you have significant periductal fibrosis from previous inflammation, whether it be like a cholangitis, how do you manage that? I came across an article talking about in this scenario, sometimes where it's not safe to get a plane posterior to the duct and the portal vein. Some persons have described doing what's known as a Lilly technique, which I'm not too sure if it's practiced much anymore, but in this technique, the most densely adherent portion of the cyst wall is retained in the hepaticoduodenal ligament. And they describe using diathermy on the mucosal lining as 50% of the cholangiocarcinomas that do develop, they arise from the posterior wall. So that's one scenario which I thought about and how best to manage. And one of the second ones is what if you have a cyst involving, so you have cystic dilatation involving the confluence of the hepatic ducts. Should we do a hepatico-judge performed to a proximal cuff of cyst, or should we try to go as high as possible proximally?
Yeah. So I think we talked a little bit about this.
Which we did, yes, yeah.
And about risk reduction. And I think the Lilly technique sort of gets to the same sort of point. Has anyone actually ever done that? I certainly have not.
Mm-hmm.
Sounds like no.
Yeah.
Okay, great.
Right.
Anyone else with any questions? I think someone asked a question about stapling off a type 2 cyst. I would not do that. Sutures, you resect it and then suture it. Any other closing thoughts from anyone?
I have just one other comment. This comes from Asia literature. Again, if you are going to follow patients long term who have any type of a remnant cyst, or if you choose to just follow them completely non-operatively, they recommend measuring a CA19-9 once a year. It's been reported that CA19-9 can rise abruptly without there being any evidence of a lesion by EUS or by MRI. So if you see a rise in the CA19-9,
it's probably a good thing to do, and then to further investigate.
So
Great, thanks. I'm going to turn it over to Rohan.
Yeah, I just wanted to make sure. Thank you very much, Kevin. And Greg, just correct me if I'm wrong. That was a really nice presentation. I just want to make sure that the fellows come away with a few things.
Sure.
First of all, type 1 choledochal cyst is your most common type that you're going to see, right, Greg?
Correct. Yeah.
Number 2, anomalous junction is something to look for that may be helpful, correct?
Correct. Yes.
Number 3, it's rare that you need to do a Whipple in this circumstance, correct?
That's correct. Yep.
And I think if you can walk away with those very simple parameters, that will be very helpful to you. And just from my own experience, just I put in the chat, I had a 16 centimeter one that was splaying the pancreas one time. Even with that, you can usually typically get away without a Whipple, because you can just imagine that this is a horrendous Whipple, right? From a leak standpoint, it's a normal pancreas, etc. Other thoughts: use of spyglass, rule out a SOD, use of a pancreatic ductal stent will be something to think about, at least in your practice. And I think that we learned today, at least from the chat and from the comments, that the incidence of cancer is actually probably lower than we think. Correct, Greg? Greg, is that right?
Rohan, can you hear me?
Yes. Yes.
Hey, this is John Martini.
Yes.
I just wanted to say I really like Scott's comments, because I think the big thing I worry about is people leave and go out into the world, and the first time they see a mildly dilated bile duct, they want to take a 75-year-old and do a major operation. It is maybe not indicated based on the real risk of malignancy. And, the other thing is that, we're much more conservative in following these patients now. And I think that we'll see that as cholecystectomy becomes more widely used, it will change how we don't just rush these patients off to the operating room. So I just would put a word of caution out there. We see that on some of these Facebook groups, like the SAGES Facebook group, people presenting mildly dilated bile ducts, and they want to take these patients and take apart their biliary anatomy in an asymptomatic older patient. I just think the fellows need to understand that not everybody needs a big operation for this,
right? Even
if it is truly a choledochal cyst, and I suspect many of them are not.
Right. Thank you. Thanks, John. So with that, I think we do have to finish up. So Brendan, word of course from overall, correct? And do you want to wrap it up, Brendan?
Yeah, so thanks. That was terrific. Appreciate Greg and Dr. Shaw's contributions. A good discussion, and obviously a huge areas of controversy in this disease. Next conference is November 4th. Dr. Helton, who made great contributions today, is going to be moderating, and Patrick from Methodist.
Correction, Flavio Roca is moderating.
Oh, got it. Similarly, his understudy, now moving on to bigger, better things also. So I think Patrick at Methodist, you're up for the presentation. So we'll look forward to that.
The title is?
I'm sorry?
Patrick, you want to tell us what you think you're going to be talking about?
Yeah, the topic that we're going to talk about is chronic pancreatitis, whether to resect or drain.
Awesome.
So
Another
that come
great
through
controversial topic.
Here in the conference room.
Really appreciate everybody's participation. I think this chat forum is a really great way to get people engaged as well. So don't hesitate to use it. We will look forward to seeing all of your faces next month.